We'll move on to the second oration, that's Dr. Eugene Braunwald oration. And this year, this oration is being conferred on Professor M.J. Gandhi, Senior Consultant Cardiologist from Mumbai. We'll have 12 minutes for Professor Gandhi to deliver the oration. As it's an oration, we'll not be having any questions from the floor. To help Professor Gandhi be on time, we have a timer straight across. May I invite Professors Naveen Nanda, M. Khalilullah, Drs. A.K. Omar, Professor Harshvardhan, Professor Asha Murthy, and Dr. Vidyut Jain to please join the proceedings on the dais. Professor Gandhi would be deliberating on management of chronic stable angina today. Is it different? Over to Professor Gandhi.
I think before we tell Dr. Gandhi to speak, I'll request Dr. Khalullah, Dr. Naveen Sinanda to join me and bestow upon the medallion to Dr. M.J. Gandhi for this most prestigious oration of our conference on the name of none other than Eugene Braunwald. Professor Khalullah and Naveen Sinanda. Asha Murthy, please join. Sir. Thank you very much. I request Dr. Khalullah to say one word or one line about Eugene Braunwald. Khalullah, sir.
Professor Eugene Braunwald is a legend in cardiology, and I think over the generations of medical students, physicians, cardiologists, his textbook is like a Bible. I had the privilege of meeting him in person several times, and it's so inspiring. Every time you read what he writes is illuminating and makes you wiser and wiser. It is befitting that a very distinguished cardiologist from Bombay, like Professor M.J. Gandhi, is delivering Eugene Braunwald memorial oration this afternoon. Dr. Gandhi, please.
My topic for today is a patient with stable CED and angina. How do we tackle them in the current era? Okay. This is Dr. Eugene Braunwald. In the year 1963, when I went to Boston as an international NIH fellow at Beth Israel Hospital, one morning my chief asked me, Gandhi, why don't you go and listen to Dr. Braunwald? He has come to Boston to give a talk on digitalis at the Brigham Hospital. I hadn't heard of Dr. Braunwald then. He says he's a very young guy and he's spoken of very highly by everybody. So I said, okay, I shall go and listen to him. He talked on digoxin, very impressive. So much so that subsequently I decided to spend a day with him in his laboratories at Bethesda. And today I feel very proud that I am here before you to give an oration in his name. I consider it a very proud moment. When you talk of angina, your patient may have angina equivalents, like he may have just a mild epigastric discomfort on exertion, or he may have dyspnea on effort, or excessive fatigue on very mild exertion. These sort of symptoms are very common, particularly in women, particularly in the elderly and in diabetics. Also, never forget that your CAD patient may have no angina, but can have silent ischemia. He may present with heart failure, he may present with arrhythmia, or he may present with sudden death. When you see a patient of CAD, your first task is to stratify the risk that he carries. If you don't do that, I think you're making a big mistake. And there are two things basically which tells you the risk the patient carries. When we talk of the risk, we're talking of either his chance of developing an MI or developing sudden death. Now, you can divide your patient into three categories: high risk, where the incidence is more than 3% annually of developing MI or death. Intermediate, where it is 1 to 3%, and low risk when it is less than 1%. Basically, as I told you, you have to determine the degree of ischemia the patient has, because that is one of the important risk factors. And number two are the coronary arteries, how many of them are involved and to what extent. In fact, recently Dr. Brunwald in his latest edition has put CT angio as one of the non-invasive tests for all patients of coronary artery disease. Here you can see very clearly that you can determine the risk of ischemia by a stress test or by stress echo. And as that risk increases, as that ischemia increases from 0% to more than 20%, you can see that death rate also increases. This is a death rate within a matter of 1 year and 9 months. Also, the number of vessels involved. When you see a stable CED with or without angina, he can have 1 or 2 vessel disease, he can have a 3 vessel disease, or he can have left main. And remember that more the vessels involved, the left main involved, 3 vessels involved, your risk of death and MI keep on increasing. What are the therapies available to us in a patient of stable CED with angina? Of course, there is good medical therapy which has to be given to all patients. Remember, the medical therapy doesn't end when you do an angioplasty or when you do a bypass surgery. The medical therapy is something that continues all his life. As I told you even earlier before, that coronary artery disease is a progressive disease and it is a lifelong disease. And that is why your therapy, particularly the medical therapy, continues all your life. The medical therapy usually includes antiplatelet therapy like aspirin, like ADP antagonists. With the newer antiplatelet agents are also coming in. There are drugs which modify your disease like statins, can cause partial regression. Proper treatment of diabetes mellitus, good control of blood pressure like keeping it below 140/90, and diabetes keeping your HbA1c below 7, and statins to keep your LDL level below 70. Arrhythmia prevention, the beta blockers do that. Beta blockers also take care of your stress. Lifestyle modification, you heard a great deal about it from Dr. Manchanda and Dr. Luz. Good diet, good exercise, no smoking. Then anti-anginals, I put them last. They are the least important ones because all that they do is treat angina. They don't modify your disease. You can have nitrates, calcium channel blockers, ranolazine, and many others. And the last is revascularization in selected patients, either by angioplasty or surgery. Remember that when we treat a patient of stable angina or stable CED with angina, there are 2 goals of therapy. The one important goal which many people forget is to improve the prognosis. Now that is measured by hard endpoints like death and MI. Are you able to reduce his incidence of death and MI? These are hard points and they will improve prognosis. So that is the first aim when you treat a patient of stable CED. And the second aim is to improve his symptoms. If he has angina, you want to reduce them, you want to make him comfortable, you want to improve his quality of life. And these are measured by soft endpoints, like, okay, angina is reduced, the number has gone down, or it has disappeared, or his quality of life. Again, how do the various drugs affect these goals of therapy? Mind you, remember there are two goals: improve prognosis and improve his quality of life. Now, anti-anginals will improve only quality of life and nothing else. While beta blockers, antiplatelet agents, ACE inhibitors, statins, surgery, PTC, etc. will improve prognosis. They will diminish coronary events and they will improve survival. And particularly important ones in these are statins. Now we know if you reduce LDL by more than 40 milligrams, you reduce your coronary events by more than 20%. Mind you, many people don't take statin very seriously. If the patient doesn't tolerate, if he complains of little myalgia, they will suddenly stop statin. Remember, statins are one drugs which are so important that you should never try to just stop them. You must use all your methods to see that he continues to take. If he doesn't tolerate, reduce the dose. If he still doesn't tolerate, reduce it further, make it twice a week, make it once a week, change the statin. So there are many things you can do, but you must try to give statins because these are the most important ones. In fact, with the newer drugs that are coming in the field, like PCSK inhibitors and mifepristone, which acts against ApoB, their effect on LDL reduction is so dramatic. They will reduce it by more than 50%. Now, whether this will ultimately translate into diminution of coronary events and mortality will be known to us very soon, by next year and a year after, when the outcome studies of these PCSK inhibitors, particularly in familial hypercholesterolemia, will be known to us. And if they dramatically reduce these coronary events or mortality, I wouldn't be surprised if all of us start using them for all patients of coronary artery disease. In the year 2007, a trial was published, the COURAGE trial, which somehow shook up a lot of cardiologists, a lot of interventional cardiologists, a lot of cardiac surgeons, as if the optical medical therapy was all that was necessary to treat coronary artery disease. Mind you, subsequently, many issues have been raised regarding this trial. Whether there was a selection bias, because they started with reviewing almost about 30,000 patients and selected only about 9% of them for the trial. So it is a very small percentage they selected of all patients of CAD. There is a strong belief that they ultimately selected very low risk group. And how did they find out? Because they found that their 8-year mortality was considerably low, which will usually apply to a low risk group. Third, they had removed the cases of left main. They did not accept cases of LV dysfunction. They did not accept cases of class 4 angina. Then subsequent studies were done from the same group of patients. One was COURAGE nuclear sub-study, where they ultimately showed that if you show by nuclear studies that there were cases where the ischemic burden was high, in that case they had a higher mortality and higher event rate. They also showed that they had studied FFR in certain groups of patients in the same, mind you, in the same courage trial. And if they found that this FFR was less than 0.8, there was a higher incidence of death and MI. So the fundamental fact remains, the greater the burden of ischemia, greater the event rate. OMT is unrealistic. Now why do I say that? You heard excellent data from Dr. Manchanda, from Dr. Luz. But recently, Bari 2D study was done some years ago, one with revascularization, one without revascularization, or only on optical medical therapy. And they found, 5 years later, they followed them up, they found that it really reduced the incidence of events by 50%, those who were on medical therapy, which is excellent. But then they also found that actually only 8% of the people continued to follow that for 5 years. And the results appeared good because of intention to treat analysis. So mind you, optical medical therapy is excellent. We have nothing against it. And as I told you in the beginning, that is a therapy which has to be continued all his life, irrespective of the procedures that he undergoes. But somehow our patients or our people are not able to carry on all their life. Only about 7% or 5% of the people were continuing this treatment after 5 years. This is again the ischemia. These are some very old slides where they compared medical therapy with revascularization. How revascularization changed the mortality. And this is after CAST study. Remember, this is an old study.
To sum up? Would like to sum up now?
Next one. Next one. I will end with this. In 2014, European Heart came out with this diagram. How should we treat a patient of stable CED? First, you do their angio. If you don't want an invasive angio, do a CT angio. If it is only one or two vessels and probably not involving proximal LAD, go ahead and do plasty, provided the stenosis is significant. And they have well defined that significance. That if it shows severe ischemia, if it shows 90% obstruction in two views, or the FFR is less than 0.8. If that shows significant stenosis, if it is one vessel, not proximal LAD, go ahead and do a plasty. If it is two vessel, also do the same, provided it is not proximal LAD. If it is proximal LAD, or if it is triple vessel disease, and the syntax score, that's a score with which we measure the intensity of lesions in the coronary artery tree, and that is if it is less than 22. If it is more than 23, probably he will go for surgery. But in spite of all these, they have still said that proximal LAD, two vessel disease, three vessel disease with less than syntax score less than 22, angioplasty shows equally good results as surgery. More than 23, probably surgery holds good. But even in all this, with the newer advances in plastic that are coming in, I think very soon you will find that angioplasty will always be an option available for all patients of CAD. The last message, the diagnosis and treatment begins with an angio. Never forget that, because that's one of the important criteria for finding out whether you're dealing with a serious lesion. If you don't believe in invasive angio, go for CT angio. Revascularization is necessary because it converts a high-risk patient into a low-risk. Third, it is not one time that you look for this. Always be on a guard to see whether your patient, which you thought was now low risk, is going into high risk. And the last but not the least, CAD is lifelong. CAD is progressive. You must stop that progression by optimal medical therapy all his life and a series of other treatments as and when necessary. Thank you.
Thank Dr. M.K. Gandhi for his excellent and crisp presentation and easily understandable by everybody. Thanks, sir. Thanks very much.
Thank you. Thank you very much, chairpersons. That brings us to the end of this oration. Thank you, Professor Gandhi.